and welcome to SureenaSpeaks, and in this video I'm going to cover the management of acute kidney injury or AKI, especially in older people. Now, with acute kidney injury, and especially when you're looking at the management of acute kidney injury, there's a few things to take into account. For example, what exactly is acute kidney injury, what risk factors are involved, identifying symptoms, and once we've looked at that, then it's easier to decipher what the management of AKI should be. So AKI, what is it? So it's defined as the rapid decline of renal or kidney function over a very short period of time. And by short, we mean very short. So this could even mean hours, or it could even be days. And this could be characterized by a reduction in urine output and or an increase in serum creatinine. So with developing AKI, there's many risk factors which can put a person at more risk of developing AKI. So for example, those with existing chronic kidney disease, those with heart failure or low blood pressure, people with liver disease or diabetes, and age is a big one as well, especially those who are 65 years or over. Now, as a person gets older, they're at more risk of having different conditions, having different comorbidities, and so with that, it means that they may be on a multitude of medication. They could be on all sorts of different medicines, and there are some in particular which put patients even more at risk of developing AKI. They are, for example, NSAIDs, so ibuprofen, naproxen, and these impair the kidney's ability to regulate blood flow. This is also known as renal autoregulation. Diuretics such as furosemide, this can have an impact on a patient's electrolyte balance, for example. Angiotensin converting enzyme inhibitors or ACE inhibitors and angiotensin II receptor blockers, so your ARBs. So an example of an ACE inhibitor is ramipril, lisinopril. Think of all those medicines that end in ramipril, lisinopril, they're your ACE inhibitors, whereas your ARBs, so for example candesartan, losartan, again your TANs, those are examples of ARBs. And these two can impair the kidney's ability to regulate blood flow, so again have an impact on renal autoregulation. Metformin can also cause a risk too, because if you think about it, metformin is cleared renally. And if there's something which is impacting the kidneys and therefore that metformin can't be excreted properly, that metformin concentration is going to build up. And with that increase in concentration comes an increased risk of side effects. What's a side effect of metformin? Lactic acidosis. And lactic acidosis can have an effect on the liver, it can have an effect on the muscles. So you can see there's a domino effect. While someone might be taking a particular medicine to help treat a particular condition, for example, metformin being given for diabetes, it could actually have an adverse effect elsewhere. And so when we're looking at a patient, particularly an older patient, and their risk of AKI, we need to look at the patient as a whole. So looking at what current conditions they may have which could cause a risk, looking at what medication they're taking, but also what symptoms they have. So some symptoms of AKI are, for example, a reduction in urine output, which is what we mentioned in the definition as well. Having discoloured urine, so particularly if it's dark coloured urine, so yellow or brown. Generally feeling unwell, dehydration, confusion, drowsiness. And as you can imagine, if you came across someone who was generally not feeling very well and feeling quite drowsy, who's to say that they're not suffering from a viral infection, for example? So it's about being able to have that differential diagnosis and differentiate one condition from another. And we can do that, again, by looking at the patient's risk factors, medicines they're taking, and symptoms, and looking at it as a whole. Now, once you've looked at those different elements, then you can think about management. And when it comes to AKI, it's not a simple case where you say to a patient, take this pill, take this medicine, and that's going to treat you from your AKI. It doesn't work like that. Management is supportive. It's about maintaining that adequate renal blood flow. Remember we said with the ACE inhibitors, ARBs and NSAIDs, they can interfere with renal blood flow. So we want to support that management that is required. We want to think about avoidance of any further injury and even renal replacement support if necessary. If a patient is, for example, on diuretics, and as I said beforehand, that can have an effect on the electrolyte balance, we therefore want to monitor electrolyte balance, manage blood pressure as well, and look at potential causes and see what those potential causes are and can they be treated. Such as, for example, if they have an existing infection, optimizing medicine choice and dosing too. A key part of management is medicines optimization. What is medicines optimization? Well, it's about understanding a patient's belief and concerns about their medication. And when you're reviewing a patient's medicine, particularly if, for example, you're in a community pharmacy role where you're seeing patients face to face and quite regularly, when reviewing patients' medication and looking at patients' their medicines optimization as well, pharmacists are best placed to provide that support and education to the patients. Say, for example, after doing a review of a patient's medicines, they tell you that they take ibuprofen every day because they think if they take it, they read in an article, let's say, that if they take ibuprofen every day, they won't get coronavirus. So again, it's about being in a position where we can provide that support, that education, the right references and resources to refer our patients onto, and provide them with that information, whilst also respecting their own autonomy as well and decisions that they want to make, but giving them that correct information. And that's why when it comes to the management of AKI, medicines optimization and reviewing is a really, really key part. There's also something known as the Stopstart Tool. Now, STOP is spelled STOPP, and it stands for Screening Tool of Older People's Potentially Inappropriate Prescriptions. Quite a mouthful. And START is the screening tool to alert prescribers to right treatments. And this weighs up the risks and benefits of a patient's medications. Is it appropriate that they're on a particular medicine? Should they maybe be on something else instead? And it's a really useful tool when reviewing patients' medicines. I will include links in the description box below with more information on the Stopstart Toolkit and general references which I think are of use. As part of patients' management as well, it's important that they know their sick day rules. So if they get sick, if they get diarrhea or they start vomiting, do they know which medicines they should stop? Do they know when those medicines should be restarted again? If their symptoms don't improve within 24 hours, do they know that then they should seek medical attention, for example? And it's important that our patients stay hydrated too, and they understand why they need to stay hydrated. So let's imagine a case study, for example. Say you have a patient who's on aspirin dispersible 75 milligrams once a day, bisoprolol 10 milligrams once a day, furosemide 40 milligrams twice a day, lisinopril 5 milligrams once a day, simvastatin 20 milligrams at night. And let's say that they have established chronic kidney disease as well, stage 3, and they have low blood pressure, 90/63. And they've sprained their ankle and their doctor wants to prescribe them with naproxen, 250 milligrams when required. What advice would you give regarding this particular patient's medicines and their risk of acute kidney injury? Well, let's break it down. They're on aspirin, which is an NSAID, be it a low dose, but it's still an NSAID. They're on furosemide, which they're taking twice a day, which is a diuretic. They're on lisinopril, which is an ACE inhibitor. So they're already on 3 medicines that we've established put a patient at a higher risk of developing AKI. They have established chronic kidney disease, stage 3, and if we reflect back, we did mention that one of the risk factors of developing AKI is existing chronic kidney disease and low blood pressure. Our patient has low blood pressure as well, and the doctor wants to prescribe them an NSAID. So it's really about thinking, would that NSAID be the most appropriate of treatments? Could they, for example, be on paracetamol instead? Would that be sufficient? Could they be on a low dose of a weak opioid, for example, codeine, which may be given intermittently with paracetamol? If the patient's blood pressure is already quite low, maybe their ACE inhibitor and their beta blocker needs to be reviewed because both of these work to lower blood pressure. So if the blood pressure is already quite low, maybe we want to withhold a few doses to try and bring that blood pressure back up. Blood pressure would need to be monitored. if that furosemide is being given twice a day, maybe actually that needs to be reviewed as well. Maybe it's better if we withhold a few doses or reduce a few doses, reduce their dose from say 40 milligrams to 20 milligrams, or instead of being given twice a day, maybe it needs to be reflected and reviewed, and maybe once a day would be sufficient. Of course, it would depend on what condition they were having, and there would be other factors to take into account as well. I'm just really trying to strip it down to try and give you a bit more of an idea of how to think about if you are ever faced with this situation and you do need to think about the management of an older person and their risk of developing AKI. With that diuretic as well, you would also need to monitor their electrolytes, as we had mentioned earlier too. So hopefully you have a bit more of an understanding what AKI actually is, understand what the risk factors are, what symptoms there are, and do understand the management of AKI now as well. This was just a summary video to try and put it all into context in a little bit, and like I said, I will put in some references and resources below of links which I think are quite useful, which to explain AKI further. So I hope you enjoyed this video, and if you did, why not give it a thumbs up? Share, like, subscribe. Do also visit my Facebook, Instagram and Twitter. Always feel free to get in touch as well. And until next time, good luck with your revision and happy revisings!